This afternoon, we'll be advancing the conversation around mobilizing government responsiveness towards addressing cancer care issue and deficits. And we are very, very lucky to have some people in the room that in the last few decades, they've dedicated their professional lives towards reshaping the policy environment in Nigeria towards expanding access to care. So we are very, very delighted to have in our midst distinguished Senator Ibrahim Yaya Oloriegbe, who is the chair, Senate Committee on Health of the Ninth Assembly. So last Thursday I was with him. With him again on Thursday. Maybe next Thursday will be. So distinguished, you can come over to the high table, Sam. So we also have somebody that has dedicated her professional life. Now, in fact, we have turned her to a medical practitioner. She's the digital guru, a technology guru that has been recognized globally for doing that, promoting technological innovation in the health space. She's Engineer Indili, the country director of Farm Access. Exactly. The test has been adopted in the and we have Dr. Baba Ahmed, Office of the Special Advisors to the President. We have, okay, you are welcome, sir. Yeah, and Dr. Razak Olusegun, Chief Consultant, Radiotherapy and Clinical Oncology. Yeah, welcome, sir. And of course, we have the National President of the National Cancer Society, Professor Abidemi Omonisin. And our cancer survivors, we should not... Sarah Oti, please. Can we have Sarah Oti? Okay, so thank you very much. We'll try as much as possible to be brief, but when we have this caliber of panelists, it's very difficult to achieve that. So to start with, I would like to start with distinguished Senator Oloriegbe, who has done very, very. For your information, Senator Oloriegbe is anything you can imagine: a medical doctor, a politician, development practitioner, civil society advocate. So it has worked in all realms that you can think of. You understand? So I'll start with him. We're talking about Cancer Health Fund today because of the great work he has and his colleague in the Ninth Assembly have been able to do. So I would like to start for the benefit of the audience. What is the motivation for the Cancer Health Fund? But more importantly, how do we scale it up from where we are so that more Nigerians will be able to access the fund? Distinguished.
Thank you very much. Good afternoon, distinguished ladies and gentlemen. Let me put it like that. I'm very pleased to be speaking here this afternoon. When I look around, I can see what we are in Nigeria, which is our demography. The youth, which is our power. It's our today and our tomorrow. So it's always good for someone like us. I'm also a youth anyway, by the way. It depends on what you define as youth. What is it? It's not that alone. At least, I mean, sorry for me to say, for most of you here, I'm sure you'll be surprised that when we were in school, there was nothing like computer. Yes, there was no computer. The computer, I think, came and met us. I was already, I'm sure Dr. Razak will also say the same. So you assume that in your hand, you can do several things. In our days, you can't get even reference. You have to, when you go to library, there is nowhere, it's only the library that is physically present. So, sorry, having said that, so that is to show where we are in the world and where we should be going. He has asked me about Cancer Health Fund. I think he asked two questions, motivation and how do we go forward. Briefly, the motivation is basically the fact that cancer, as it was then, was known by many. I said then because now it is a little bit better. It was known as a death sentence. That's one. Two, a death sentence because once somebody is diagnosed as cancer, they will say, when will the person be buried? That is the next question. Or the person herself or himself will also think, well, my days are numbered. Of course, there are several reasons for this, as Gafar said last week, Thursday we were talking. It's because many Nigerians don't get diagnosed early. It is only when it is late. But two, and more importantly, is that several of the people that are affected, cancer is the highest, I would say the disease that push a sufferer into poverty immediately. Gafar presented a slide, I'm sure we'll be talking about that last week, which shows that everybody, if you see all quantile of wealth, of hierarchy, not only if you are poor, even for average, what we call average rich people, even for rich people, the quantum of their resources or the proportion of the resources they have to spend when they are diagnosed as cancer is very high. So it wipes out, even if you are poor first, you can't even start. If you are average, you go back to poverty. If you think you are high, the amount of money is something that you can't afford. So in which case, what we see is we see a lot of Nigerians, even if they will have opportunity of surviving, they can't survive. Even when they survive, for the few years or period they survive, it's in suffering. So as elected representative of the people, and as he said, based on one's background before I got to National Assembly, being aware of this, we wanted to make a difference and a change. So we were approached again by civil society groups that are advocating for cancers, led by the then First Lady of Kebbi, who is also now the president waiting for International Cancer Society, Her Excellency Dr. Shinkafi, and some other people. And they said there has been something in the offing, a partnership between the government and the private sector. The private sector was very critical there also, because the private sector came on board to say that if government puts resources, they will match it with contribution. So the drug manufacturing company, the equipment companies, they were there. I'm happy she is here. Our producer then, Claire, yes, was part of the team. And then when they presented their case to us, what was required is for the money to be in the budget, the government part. So we use our duties or responsibility as parliament, which is appropriation, to get money out of the national budget to start and kickstart Cancer Health Fund in the 2020 budget. And we're able to get 750 million naira into the budget then. It's not 750 million naira of today, because 750 million of 2020 is times 5 of today, because the naira exchange then was less than 350. So it's 1,500 now. So it is, I just put it on there times 5. So if you say minimum times 4, that is why, like, we are putting 3 billion naira is what we of today was what we put in the budget. So that is, we said then, because as I said, suppose we put it specifically in the budget to be government counterpart in the public-private partnership for cancer fund. So, and the thing is that we focus on 3 cancers based on epidemiology again. For women, the breast and cervical cancer, and for men, prostate cancer. Third, the condition we put is to support indigent population. Well, as I said earlier in my introduction, everybody's indigent as far as cancer is concerned, but some are more indigent than the other. They don't even have the opportunity of any family or other support. That is it. But I think we've learned lesson. That is just because of time. Going forward, one, what do we need to do? The Cancer Health Fund that we put there has gradually been diminishing in terms of the quantum of money being put. Rather than it increasing, it's reducing, very unfortunately. And I think one of the things we need to do is to get government to increase that fund. That's why when I speak, I say 750 million naira in 2020. It means today, we mustn't be thinking of anything less than 5 billion for us to start, to say that we are about. But unfortunately, we don't even get to 500 million in the last budget. This is not entirely the problem of government. It's also the problem of the system. Because the money we put for the first 2 years, unfortunately, was not used. We have to use we have to now use our oversight functions to put pressure for it to start to be used. As such, you know what happened in government, particularly for finance. You are putting money, you are not using the money. So they won't put more. So in which case, as advocates, as groups, we have to put more pressure to get that money there. But two, we need to expand it. And I think we started this with the support which I got from some private sector, Roche especially. Sometimes in 22, immediately I exited in October, we were able to call all the National Assembly chairmen together. And I was able to, I would say, effectively hand over to the current chairman and tell them the stories that I'm saying and charge them or advocate to them to support, continue to support. So they've created now Cancer Fund for Children, but it's not funded effectively again. So we need going forward to get that done. But beyond federal government money, we are a federation. We have federal government, we have 36 plus 1 state, that is 36 state plus FCT. The state also have to do similar things. Because without that, we can't have enough fund. But far and beyond that, that is public funding, the public sector funding. We need to also look at other stakeholders that contribute. We have money in the private sector. As I said, the Cancer Health Fund philosophy was for it to be a partnership between the government, which is the public sector, and private sector. We are defining here is not only corporate body. We look at development partners, international organizations, international philanthropists. They also need to come in so that the intent of that fund will become the true port it should be. Not only we have only public fund, but we have the private sector. The drug manufacturer is only Roche that I see now that is there. We have other drug manufacturers who manufacture cancer drugs. This also will be coming on board. Because Roche now have a program where they do what we call subsidy. They give a discount of 30% of the cost of the drug. The NHIA match up with 20%. The patient pay 50%. But we need to get better with that. Thank you very much.
So thank you very much, distinguished. We really appreciate that. You can see responsiveness in action. Somebody saw a problem, a design in solution, and it actually provided the leadership to ensure that that solution translates to action. Distinguished, you will see a beneficiary of what you've designed speak to how it has, from the human angle to it. He has given us the policy angle, human angle, somebody that actually benefited from this, you will see. But before I do that, there's somebody we omitted from this panel. So can I invite Pharmacist Abbas, Head of Market Access, AstraZeneca? Pharmacist Abbas? It's not the photographer, right? Okay, he will join us later. So, Madam Hoti, hello, Madam Hoti. What you benefit from presently on the Cancer Health Fund is what distinguished Senator Oloregbe has described in a nutshell, what they describe. Can you share your experience? How has it actually helped you?
My name is Sarah, Mrs. Sarah Oti. I will say that I'm a beneficiary of the CHF. It has actually helped me. When I finished my surgery, the mastectomy, I had no money. We ran out of money. The money was not there because at that point in time, my husband was sacked because he was always there with me in the hospital. So we were always begging people, friends, church members, you know. Some persons responded and some did not. But in the hospital, I told my doctor, I'm out of money. I don't know what to do. And there was delay. So my doctor told me I should go and fill the form online. I did that. And she followed it up. I was called for physical interview. I went. I thank God after some months, I got it. It actually helped me because I had no money to go for radiotherapy as at when I was sent for. So the CHF actually helped me a lot. And so many persons too benefited from it because they were actually out of money as well. So many died. I thank God for the doctors we have. They have compassionate hearts. They look out for us. So many of us that couldn't get money, they were able to put in our names and put pressure. And at the end of it, we were able to access the CHF. So we are really happy for it.
I think she deserves a stronger round of applause. Distinguished, you must be feeling gratified inside you that you.
I told you, last Thursday I cried because I saw a person giving the same testimony. I cry for joy, but I also cry that we need to do more. Thank you.
Okay. Thank you very much. So let's hear from the provider perspective. Dr. Razak Olusegun, you see this patient, you've seen different type of patient, those that despite the best of your knowledge and ability, you are not able to help them because the resources is not there. How does it feel to have this type of fund supporting the patient? And what are the gaps? Because the largest room in the world is the room for improvement. Can you articulate that, please? Thank you.
Thank you very much. Is it one of the, I will say categorically here, and some of my colleagues here will agree with me, one of the most frustrating jobs is to be an oncologist in Africa or in Nigeria in particular. It's very, very frustrating. Frustrating in the sense that you see large volume of patients that you can help, and unfortunately you are handicapped. There are quite a lot of problems, actually, that we cannot mention them all. But let me confine myself to the CHF that I share at the National Hospital. You see, the distinguished Senator Olorebe mentioned that the first year the money was not utilized and all that, which was true. There are 6 centers that are charged with the responsibility of taking care of patients on these CHF. But unfortunately, all the 5 other centers combined, they don't have the volume of patients that National Hospital has. Because everybody is in National Hospital, whether you are from Gombe State or from Enugu State or from Anambra State or from whatever state you are, Ogun State, everybody is in Abuja. So, but funds are allocated according to centers. So, while National Hospital will have exhausted all its own fund, the global picture will still be that there is still fund in that thing. And some centers are suffering more than others. But with the floating of the naira now, the drugs, with the cost of the drugs, they have escalated massively. Now, even if you allocate fund to this, I was talking to DG, the representative of DG of NICRAC, even if all the money that, but since then, the volume of patients had picked up such that the volume of patients we have now, even if they give us 300 million that all the NICRAT has, we will exhaust it in 2 months. Because for each of the breast cancer, for most of the breast cancer patients, they need allocation of 2 million every 3 weeks. The same thing with prostate. If the drugs are available, the Zytiga now costs 1,094,000. So even if you allocate 1 million, it's not enough. If someone will be taking Zytiga plus Zoladex plus Casodex, 2 million will, and this will continue every 3 weeks. Not to talk about radiotherapy. So is the funding right now is such that it's not forthcoming regularly right now. But still the global picture with the CH fund is that, there is still fund in the TSA account at the central bank. But some centers have been depleted, and it is not easy for those who are operating it to just move fund from other center, like move from Zaria to National Hospital or move from Enugu to National Hospital. It's not so. The global picture is such that we are not utilizing the fund, but we are utilizing the fund. So it's just that some centers are more overwhelmed than others. But what I praise the effort of the Professor Omonisi about his effort to galvanize for funding when he spoke in the morning. Because this thing, cancer is no respecter of person. The children are there, we have not incorporated them, we have not included them, and it doesn't respect anybody. I lost a friend recently, about a month ago. He was a professor of medicine, retired in Ibadan at the age of 70. And almost immediately retired, he had pancreatic cancer. And he sold his house, sold everything. And the last 2-3 months, it was the MD of the hospital he was attending that had to be paying for fund for him It was my father's physician in Ibadan. When my father was alive, it was my father's physician. So we were very close because he took good care of my father. So what I'm saying is that anybody could be affected.
Absolutely.
I've seen several years ago.
So Dr. Razak, I have to come in here. Thank you you've made a very, very important point, and I got it when you say it's very, very frustrating, just to be an ecology, but VHF has made you to be less frustrated, to be work to be less frustrating to you. But of course, like you said, there's still other gap. I will still coming back to you in terms of it. So let me go to Pharmacist Abbas. Pharmacist Abbas, so there are issues around availability of drugs, some specific drugs. Some people raise issues around regulations around some drugs and all those stuff like that. From somebody from the farm sector. So what are you and your groups doing to ensure that the necessary commodities are actually available and they are accessible, they are affordable? What's the contribution from the farm on this perspective?
I'm putting it right there. When is your company also coming with their own?
Okay, subsidy too. Thank you very much. Thank you, distinguished.
Thank you.
Absolutely, the social angle to the absolutely. Okay, we are putting you on the spot, so.
Absolutely. Thank you very much, Dr. Razak. Also, thank you very much, Dr. Gafara, and also distinguished senator. So, when you talk about availability, the question is, are we talking about in the premise of the hospital or outside the hospital? Now, if we look at in the premise also, because we have different channels. Now, in the premise of the hospital, the drugs are usually available when all the protocols are followed through. Unfortunately, up until August last year, the hospital channels were ran dry because why? The CHF was not being remitted as at the process aligned with. So that made the partners involved in making sure these drugs to be available in the hospital not to be able to follow through again. However, in other channels, which is outside the hospital, the same medications are available. And it will interest you to know, so I'll go back to distinguished senator's question that 2021, 2022, for example, Dr. Razak was talking about Zoladex availability and also prostate cancer. So the medication was available for up to about 400,000 naira. And with our coming on board on NCAP in 2022, we have been able to support the system that Zoladex is now available at 60% discount of that. Thanks to NCAP. And CHF has also supported with that as well to make sure, just like Dr. Razak has been saying, I can categorically support his statement that National Hospital is one of the centers who's been ensuring patients benefit from Zoladex too, which means that the patients on who are suffering from prostate cancer can be sure that they have access to quality medicines and also their symptoms are alleviated in time. Unfortunately, again, until last year, August, this channel has been dry. So earlier on, I was talking with Dr. Razak. There's nothing we can do from the end because we've engaged the partners to see how they could speak to their finance department and see how we could probably put some alleviation system in place. But that's not been helping because they come back to us and tell us, as much as you're the drug provider, we need to follow through with the protocol, which we agreed with these partners. And we're still battling that up until this morning again. I was also with the same team members. So these are things that we've been saying. Moving from prostate cancer to lung cancer, which is a space also that is really, like we know, lung cancer is one of the ailments that usually high mortality rate among all the cancers. Now, I want to appreciate the CHF fund from moving from 1 million to 5 million naira. This has really helped the system to say, yes, there's hope. If at all, we can now include lung cancer among the cancer catastrophic health funds as well. This will also help patients to be able to afford 1 month of care for lung cancer treatment. What is 1 month? We have one of the organizers in this room who had a patient that I remember I was engaging with the oncologist and said, I don't think that man is going to see another 1 week. On placing this man on the medication, as I'm talking to you today, the man can climb the staircase. Now imagine what he wanted to do for the next 1 month. So I want to say thank you again to the Ninth Assembly to say move the fund from 1 million to 5 million. That has been able to give hope for the patient to say yes, they can be able to access medicines. Now we need to make it work. Thank you.
Okay, thank you very much. Thanks for that great, especially the subsidy part of it. I really appreciate it. So let me go to the private sector now. So NGD wear two hats. We can see only one at the moment, but uh, of course, the country director of pharmacists, where she did a lot of tech thing, a lot of program in the area of health. We at the same time the president of the ECHA Federation of Nigeria, and predecessor just walking. Welcome, madam. Yeah, thank you. So I want to ask from the perspective, so two questions in one. We have been doing a lot of improvement in quality of service delivery work. How do we apply this to cancer care delivery? Then how do we mobilize under the auspices of ECHA Federation of Nigeria, private sector to support expanding access to cancer care in Nigeria?
Okay, thank you very much. And I must say I was so unprepared. I was just having coffee when
Because
I
you are
was
always
drafting it.
prepared.
First of all, I must say it's heartwarming to hear what the Cancer Fund is doing. And I must say that I'm sure you know that Healthcare Federation was the one that sponsored and pushed and advocated for that Cancer Health Fund. So it's really good that it's working now. It took a long time, but from HFM point of view, private sector point of view, there's not one private hospital that is benefiting from that fund, even though it was private sector that pushed for it. I made that case the other day. So I think it's something that we need to do because private sector still has the capacity. You're talking about national hospital being overwhelmed, but there are tons of fantastic private sector hospitals that can provide services, but yet they've been excluded from caring for patients under this fund. Having said that, in terms of quality, we, as you know, as Farm Access, we promote quality of care, the safe care methodology. We come from the point of view that quality of care is so integral, and it's about the infrastructure, the equipment, the processes, and the people. One without the other, you could get a variable outcome. And regardless of the hospital, whether it's public or private, quality remains. I'm glad he stepped into the room when I was talking about quality because he is the chairman of the Standards Committee for Tertiary Hospitals. So welcome, sir. So the point I was making is that quality is so integral, and it's not just about cancer hospitals, it's across tertiary, secondary, and primary, across equipment, infrastructure, processes, and human resources for health. It's so important to have a standard way of, applying across all facilities so that you can actually benchmark and monitor. Because as we say, what you can't measure, you can't improve. So we've been doing a lot, and there are testimonies. Some of you may have heard of, even government hospitals like FMCA, Butemeta, Ikorodu General Hospital. There are quite a number of public hospitals that are coming on board and doing fantastic, as well as private sector. So for us, it's not about, the beauty about a safe care, our quality improvement tool, is that cuts across at least 13 domains, including, so regardless of the disease profile, it's about, making sure, so imagine a T shape. So T is safe care, but it can also go down into different disease profiles. I must say for NHIA, we just developed almost 25 quality tools for different specialties. So it cuts across. So for us is how do we get the government to adopt these standards, which is why I'm very happy Professor Abiodun is here. We've been engaging with the Minister of State for Health in fact, it started with Dr. Lausa, and unfortunately up till now, more than almost a year, just to sign an MOU is still stuck somewhere, which is a frustration for some of us that you put in so much effort. You see something that works, and incidentally, this conference is about innovate to accelerate, but for UHC. Yeah. What are we innovating when there are already innovations that have not scaled? So for us is how do we, my preaching is we need to start moving. We've talked enough, we've developed policies, everything is there, but we are not moving. So how do we get that ball rolling? So I'll stop. I'll
So
stop
thank you
there
very
for now.
much. Thank you very much, Njidi. I think the discourse around quality is so important because globally, the first thing that accounts for mortality is people don't have access. The second thing is that people don't have access to quality care. So I think as we advance conversation around expanding access to cancer care, we should be mindful of our quality of care that people are receiving as well, so that we'll be able to optimize the resources. Okay.
Last comment. The last comment I was going to make is that the Lancet published that more people actually die from poor quality than no access. So that's why it's really important that quality becomes the pillar around which we develop and accelerate UHC.
Absolutely. And one bad thing about poor quality of care is that you still spend money, but at the same time waste the resources. So thank you very much. So Dr. Monisi, you listened to the conversation. I'm very sure Nigerian Cancer Society was part of the advocacy movement for Cancer Health Fund. Then how do you want to take this forward? So we have seen that it works. That's the good news. And we are getting gratifying news from the survivors that are beneficiaries of Cancer Health Fund. But there's a huge gap, part of what we have discussed earlier on. But can you quickly summarize how the Nigerian Cancer Society want to advance this conversation so that by the time we're converging, maybe next year or something, we'll have triple, quadruple the number of beneficiaries, if not more? Over to you.
Yeah, thank you very much. Just give me a few minutes to sincerely appreciate our distinguished Senator Brian Onore Egbe. I can tell you for free, his contribution to healthcare in this country, transverses cancer, and one of the national leader of, thank you very much for that. And one of the national leader of Nigerian Medical Association for 6 years unbroken. It was my election as president of the Nigerian Society that migrated me to be more active here than then. I can tell you the role he has played in improving, healthcare, in this country. It's not only cancer. Cancer is just one of what he has done. As the chair of, Senate Committee on Health, quite a number of bills, he fast-tracked, things that are not working begin to work in virtually all the sector in the country. Thank you very much, sir. We need to celebrate it, sir. I was with him in Lagos, a few weeks, I think 2 weeks ago, when the Fox lady had their, election, and also celebrating. It's one very senior member of the Nigerian Medical Association that we are very proud of. He used that position to advance healthcare in the country, not only for doctors anyway, for all members of the healthcare. Thank you, sir. Well, what we are trying to do, as we have said, his committee, that Senate did a lot in cancer space. And during their tenure, we got the bill signed to law. NICRAT, started. Pioneer, yesterday, quite a number of things, started, and cancer space. But more importantly, we have the Cancer Health Fund now in operation. But we know there are serious challenges with that in accessing the fund. Prof just mentioned to us, National Hospital, last couple of months, some people are not to assess that. Government bureaucracy is also one factor. They're also there. It's also not covering all cancers as we speak. It's only breast, prostate, cervical, and now we are happy that 2025 budget, child cancer was also added to it. But of concern to us is some cancer that actually killing Nigerians now, that is not captured by that fund. For example, colorectal cancer. Quite a lot of Nigerians having colorectal cancer, and people are dying of colorectal cancer, and nobody's talking anything about it. And there's no government support to fund colorectal cancer. We also have blood hematological malignancy, blood cancer. That's another one that's also killing Nigerians. Children having leukemia, adults also having leukemia, and people are dying of that. So the summary is that government alone cannot do it. Many of us travel to other parts of the country, and we see the role of private sector. So the earlier we find a way to bring private sector into this business, so that we have PPP of within, the better. Of course, civil society organization like ours, we will not sit down and continue to mourn with our cancer survivor. Cancer survivor, they are member of the Nigerian Cancer Society and Association, and every day we keep on hearing reports. What I mentioned, for many of our patients, members in our cancer survivor, they are not on medication because they cannot afford it. How many people can afford to maintain ourselves, 1.5 million average, of chemotherapy in a month? How many people can afford that? Breast cancers have said from diagnosis to stabilization about 22 million. How many Nigerians can afford 22 million? So it's a major issue, which in Nigerian Cancer Society we have taken a body. Number one, to also set up an independent National Cancer Intervention Fund. We're working closely with NICRAT to complement what we are doing. The fund is not, to compete with them, to complement what they are doing. We've identified some key cancers that are not covered by government, bring that into that. Then more importantly, we want this one to be, cancer survivor driven. The one of government, the input of cancer survivor is minimal. And we think that you cannot be taking decisions for cancer survivor, and they are not there at the table to take decisions. So the structure we are setting up now, we have independent, government, governing council, and our ambitious plan is to generate 100 billion, in the next 5 years, minimum, to support cancer survivor, to cover all cancers, and emphasis will be on those cancers that have not been covered. That is one strategy that we are thinking. And as I have said, it's an independent governing council. As the president of the Cancer Society, I have not seen what happened there. That's why we have appointed credible people. Dr. Gaffa is the chair of that governing council. People of private alliance are there. Governor forum are represented. Because we must bring in governor into the forum. The federal government have done a lot, but the gaps in cancer care in this country is at the subnational. There are states in the country, I will mention name, up to 10 states, sir. There's no single machine that can do mammography there. How much is the cost of mammography? You can't find it in any public hospital. In those states, the few that you find is private hospital. And no private hospital, they are not recognized, they are not empowered. They'll give them every taxes to support them, they'll say they are private. Anything going to that state, they'll say they cannot support them because they are private. But they are servicing, Nigerians in those hospitals. So that is one major issue that we have, and that's why we're organizing this to supplement that. I just finished a tour of some private oncology services, some part of the country. I was at a lecture in Maserut and other places. It will interest you to note, sir, that we now have a kind of reverse tourism in this country. People are coming from the UK, from US, to access care in those private oncology services. And those are the centers that Nigeria we are not supporting. They have capability to expand their facility. I was at lecture. Lecture said they show me their master plan to build their expanded facility, but they have no resources. Maserut, the same thing, want to expand, no resources. So how do we support the private sector?
Okay.
And the way that, what we're thinking of is that, and we need the input of our board senator to assist us. Our plan now is to recommend to the government to set up what we call cancer bank. This cancer bank, will be raising head bank many years, but we are more concerned cancer bank, is that let the federal government, provide certain facility with themselves with CBN, where private sector, people involved in cancer care can access at no interest. Government have done it before in this country. When COVID-19 hit the country, airlines were down. There were a lot of stimulus to stimulate that sector. And we know cancer now does not respect the rich and the poor. Why can't government also do special intervention to assist us?
Okay, thank you very much, Professor Molise. I know because you are very passionate. If we ask you to continue, you continue to tomorrow. That's a very great one. I think it's very gratifying to know that Cancer Society is leading effort towards supplementing existing intervention, especially looking at the cancers that are not covered at the moment, because the sufferers of this cancer are Nigerians as well. They're suffering as well. Of course, the reason why we prioritize those ones is because of the volume that we have as well. So we also have somebody represented in the room, somebody that is very passionate about advancing health in Nigeria, and that has used that opportunity in various positions to advance the universal coverage course in Nigeria. So we have the special advisor to health to the Mr. President, of course, Dr. Salma Hanas, ably represented by Dr. Baba Ahmed. So Dr. Baba Ahmed, so we are wearing the hat of the special advisor to the president at the moment, and whatever you say, you are speaking the mind of the special advisor. So you have listened to the conversation. Most of what we are talking about, even if we want to mobilize resources from the private sector, we still need government support, endorsement, and providing enabling environment. I'm very sure Dr. Salma is very, very interested in this. What has she been saying in terms of how she wants to support advancing access to cancer care in Nigeria?
Thank you very much, moderator, other panelists, distinguished senator. It's a pleasure once again to be with you on the panel and the other panelists. Distinguished ladies and gentlemen, I want to debunk something. I am not Dr. Salma. I cannot fit into Dr. Salma, and I can't be speaking for her. What I will do is to talk on what the policy is as far as I can. Obviously, it's not just cancer. If we look at the health sector in this country, and a whole lot of other sectors, the health sector is unique. For me, the Sustainable Development Goals it's like a web, and at the center is health, because we are looking at the social determinants of health. You see, the issue always is, when we talk about health, we see it as an entity. Health can't sit alone, can't operate alone, can't function alone. And in that regard, is the government came in with the Renewed Hope Health Agenda as an offshoot of the Renewed Hope. And in it has the 6 building blocks of WHO with 2 other elements. And in those 2 other elements are key. Things around partnership and things around citizens' engagement. The president when he was talking, he mentioned, where are the cancer survivors in the decision making? Because oftentimes what happens is that this exclusive list of our health system, we also look at it from the point of view when we are engaging patients as if they belong to these 3 layers. There is no federal government, there is no state government, there is no local government when it comes to health. We're all Nigerians. Now, a health that is not available, that is not adaptable, and is not responsive to the needs of the people is not health. And unfortunately, that's where we are. Everybody thinks that federal government is the sole entity, sole responsibility for health, but it's on the exclusive list. Now that the federal government has done its bit, what are states doing? Just like the president had said, there are states that do not have anything, not at all. What we're even saying is that, okay, complement. Can you give us a register? Give us data, and then let's see who it is you can support. Now, as an office, it's an advocate. It advocates, it tries to create alignment, and then it tries to make sure that the priorities of Mr. President is at the forefront at all the 3 tiers of government. Now, really, for us to engage, to push this discussion further, the key thing is not about the regulation, it's not about the policies. It's translating those things to action.
Absolutely.
Because absolutely, our problem has always been implementation, and it's subnational level that does that. So the focus should be on how do we make sure that we walk the talk. Thank you.
Okay, thank you very much. Walking the talk, very, very important point. And we are very happy that, of course, the office does advocacy and alignment. I'm very sure cancer issue align with the priorities of the special advisor. So on this note, we'd like to take a few questions or contributions. Our time is fast spent. Exactly. So just take like two, maybe one from this side, one from the other side. Ah, our header in the room has already captured the slot, right? Okay, any other one? Okay, great. Okay, over to you, sir.
Dr. Gafar, give me time, please.
It's not me.
My name is Professor Tajuddin Olasinde from Ahmadu Bello University Teaching Hospital. And I will tell you Zaria, where I even mentioned the institute. You see, I look at all of you at the panel session here. Who is speaking for the people? Okay, thank you. I will speak. You can see my voice now? Okay, anyway, the issue is how I wish some of you were here when we started this program. We've had different issues, and I'm happy the Director of Clinical Services, Nikrat, before he left, he adheres to some of these things. When we are talking of the National Cancer Health Fund, when I came in this morning, Dr. Yeshegun, you can bear me witness. The last call I received before I switch off my phone was from a patient who told me, "Sir, I've finished my Zytiga. I cannot continue just for 1 month. I cannot continue again." I told him, please, try as much as possible to continue. Why am I saying this? I don't know, maybe you will respond to this. You see, I will not just give my patient any drug. I told you here, lot of our drugs today, especially cancer drugs, they are substandard drugs. How they are getting to the country, I don't know. And somebody, I just said, the drugs are there, they are available. I'm from Zaria, and I can tell you, some of those drugs are not there. You see, even when they bring the generics, you cannot compare the generics with the standard drugs. Somebody was talking of purity here. Yes. When you want to get results, you have to give patient what will help the patient, not what will add more damage to the patient. The Zoladex you mentioned, I'm happy if you are working for that company. 9 out of 10 Zoladex available in this country today are fake. Quote me. Quote me. We are the one at the receiving end. So, what I'm saying is, what are we doing? You see, the cancer health fund, sir, I have patients that could not access it in the last 6 months. And I'm talking, look, if they're accessing it in Abuja, it's a different thing. This is the seat of power. No, let's say the truth. This is the federal seat of, they are in Zaria, no access in the last 4 to 6 months. And of what use is, why do we have policy for something that we cannot continue? So, yes, sir.
The appropriate authority, as we may call it, are not in the room. For what you are saying, I'm sorry to say, though, just hijack. These issues you highlighted, they are very painful. I mean, I feel pain that for cancer drugs, we are getting fake and so on. So, and I think we have the advocate here. What can be done, we can take care is to say, we'll raise it up. I want to assure you that as we leave this place, I will call the director of pharmaceutical services in the Ministry of Health, link up with NAFDAC. I will take it up to the Minister of State and I will send a note. Because that's the thing. Because what is there is that we have a system, it's a system failure while we're having that. Of course, not only cancer, many drugs that are fake in the country, but For cancer, again, where we are talking about cost, we are talking about suffering for that to happen. That's one. The issue of access to cancer health fund in other places is also an issue of system failure. The system is there. We had one meeting one time which I joined, and this kind of issue was raised. It's more of what's happening because they set up a criteria and so on. So those policies are things that, with due respect, sir, we can communicate it. So, and that's what should be the role of the cancer society. They should be able to be the one to open any doors or knock on any doors to get it solved. But this other one fake, I can assure you, I will get across to the Minister of State that I had this and they will do it.
So thank you very much, distinguished. I think that's the only question or contribution we have. We would like to ask our panelists to give a closing thought. Distinguished, let's start with you. What's the piece of advice as we move on?
Well, I think the piece of advice is just to what we have listened to here. One, I wouldn't know what people have put this together, but to say whatever has been discussed, can we articulate and let's move it forward. The one thing I saw here, and I merged it with what I had in Lagos when we had a FLAC meeting, the private sector are treating large numbers of patients. But Seru said in the last 5 years she opened, she has seen 5,000 patients. Now it can be assumed that it is only the rich or those that have less, but no. There will be indigent who goes there. So if you want to open access, we should expand cancer health fund beyond the government sector. But it's not talk alone that I want to say. It's about we have to engage more with the government. You know, the challenge is that government money has some financial regulations to how it is spent. So, but we need to work around it to be able to get it to where I want it to be. It's not as if anybody sitting as minister will not want that money to be, but the civil servant will tell to say that this money, what we are doing because of the government, the rule that has been put there. But of course, the rules are not set for this. Rules are set to be able to be implemented. So I think HFN, you have work to do on that one, because just like Dr. Cheko said, we have people in Abuja. Abuja is attracting people because they have family here. When people here, he treated one of my sisters many years ago. She was receiving treatment not only because they refer her here for radiotherapy. That's why she's already coming. Otherwise, she was receiving treatment outside there. So several patients that will come to National Hospital is because in one way we say that's where you will get it. And there's additional money to that. So as such, HFN, that's my second point to say you need to do that. The third one is what Prof said. I think whatever are the issues, we need to articulate and let's engage. Whoever are the advocates that are here, engage the appropriate authority. Most of these issues we talk, but don't talk. Let's do what? Walk the talk. Thank you.
Thank you very much. Distinguished, appreciate. At point are well raised. Anjude, any last thoughts? 30 seconds.
No, I think I'll take you up on that. Actually, yesterday, or was it 2 days ago, we actually had an appointment with NICRAT, but because of the public holiday, it didn't hold. So we are actually trying to follow up because I think it's very important. And that way we can expand it. And as you say, the long-term view is how to include cancer care in the benefit package. Ghana has done it. Kenya has done it. So it's not beyond the realm of possibility. So, but it's one baby step at a time. So we'll follow up with NICRAT.
Absolutely. Thank you, Dr. Razak. Any last thoughts?
Thank you very much. My last thought is that the Cancer Health Fund was supposed to be pilot. That was why it was covering only 3 cancers. But we have not moved 5-6 years after. We have not moved from the pilot stage.
Like, we are always suffering from pilotitis at times, right?
So our
sorry, sir. It wasn't supposed to be a pilot. The 3 cancers were chosen basically for epidemiological reasons, and it's not. But the thing is, if we succeed in that, we can expand to others. But it's not a pilot.
We have succeeded.
It was supposed. Hold on, we have not. I'm sorry, but we need to make it much better. We have not because the money is going down instead of going up. That means we failed. That means we failed. As far as I'm concerned, we're supposed to get more money if we have succeeded. 2, it means it failed again if I'm hearing what he's saying and what you said. In Abuja, your money is used. In Zaria, they are not using the money. In Enugu, they are not using the money. We have failed. So we all need to come together. The advocates, survivors, Cancer Society, HFN, FLAC, and put the pressure where it should be put. 1, put the pressure on National Assembly to increase the money. We did that last year. I wrote a letter on behalf of the advocate group to say, let's increase to minimum of 1 billion naira. I wrote to the Minister of Budget and Planning, but it required a follow-up. It didn't. So, sir, it's not a pilot, but we need to go. But child cancer, we said 500 million. They didn't put it there. We said let's start with that. This 2025 budget, they only put 20 or 20. So which cannot treat one or two patients. So I'm sorry to hijack, but okay. I'm passionate about this issue, and I always like more of action than us talking. So stakeholders, let's come together and put the pressure where it should be for us to move on. Thank you.
Okay, thank you very much. Please, Pharmacist Abbas, any last?
Yeah. Thank you very much. So I want to appreciate all the points that have been shared. For me, the takeout is the implementation. And just like Prof. Tajin was saying, yes, in Zaria, I was actually in Zaria 2 weeks ago, and it will amaze you to know this, the CHF funds are stuck in the system, where the chairman of the CHF is not moving, the documentation patients are suffering. And speaking about counterfeits as well, unfortunately, it's quite unfortunate. Nobody wants to know the quality of bread as long as that's where my money can buy. So that's the part about counterfeiting, because you have the systems that's been put in place, and unfortunately this cannot be accessed. I had to move across northwest Nigeria for the whole last month, and good thing is we've been activating ECHAlliance for respect to those that have for the 2025 ECHAlliance budgets that has been allowed for those oncology medicines to be there. Like we talked about Zoladex and some other things, the patient can pay 40,000 naira for that, which the facilities are appreciating this, and they're giving the patients. So, yeah,
it's okay. Thank you.
Zaria benefited. So I just want, before I go, so I want to speak to the farmer access as well. So it's a thing that it's not about NHI as well. The HMOs as well are aligned with this, which takes me to the private sectors as well, because we see most of these patients in the private sector, not even in the public sectors, unfortunately. And interestingly, going across the country, knowing that this is what we need to keep advocating, keep sensitizing. So my ask is, can we all collaborate to make sure that where one feet cannot reach, the next leg can reach as well? That will help us to be able to drive implementation. Thank you.
Okay, please hand over the mic to Madam for a last thought quickly.
Okay. I want to say that as cancer patients, it's very challenging. And as such, we need more support from the government, from the private, from every individual. Everyone should be involved, because no one knows tomorrow. We are here today.
Absolutely.
You might be the next tomorrow. So as such, we need to do something to stay alive.
In fact, all of us are already affected, so that's good. Okay, Dr. Baba, quickly, anyone? Then the Professor, what is the last person?
Okay, I think the issue, the thing here is there's need for continuous collaboration, because it's about resource mobilization. Systems needs to be speaking to each other, government to government, government to the private sector, government, community, because we're all the people, we're all the community. When we talk as if it is we and them, but it is us. So until that begins to happen, then, and the second thing is, let me allude to what Prof said. It's not just enough that we're talking about policies, about regulations, the implementation, because the policy is useless without the implementation.
It's okay.
Yes.
That's no. Thank you very much. And lastly, Professor Moniz.
Yeah, thank you so much. Well, I want to concur with what our Distinguished Senator have said. The National Assembly actually tried to be candid with us. They put a lot of money in that fund. The problem we have, the implementer refused to disperse the fund. I remember bill up to this, 2025, like, we lobbied the politicians. And they said, the money we put there previous years, people didn't spend it. That they are government priorities. You can continue to put money there. That they put 750 million in the fund. The second year, the money is still almost 700 there. That means there's no people having cancer, no people have the need in the country, and there are needs everywhere in the country. Following year, they put the money there again. It wasn't exhausted, and you want National Assembly to increase the fund. They said things doesn't work that way. That the one they put there in the previous year, go and spend it. If you finish it within first quarter, we can push for some budget. So that is the issue. The good thing about it, we had the ministerial meeting with the minister 2 weeks ago in Abeokuta. And those are some of those issues.
Try to summarize.
Yes, that's some of the issues that we raise. The minister on top of it, to address those issues. Thank you.
Okay, thank you very much. You agree with me that we've had very interesting conversation. As we are talking about, oh, we have money we are not able to spend, it reminds me of in the 70s, the president told us that money is not our problem, but how to spend it. Head of state, money is not our problem, but how to spend. But 50 years after, we are still saying we have money we have not been able to spend. But, but I think a number of important things to quickly summarize. To start with, I think we have to celebrate our island of successes. We solve problem, we design intervention, it works, some people benefited. We have to appreciate that to start with. And we appreciate everybody involved in that. Because as Nigerians, we like negative narratives. This doesn't work. This doesn't work. What are those few things, few people that have benefited? And again, that's those Gen Zs, that's what they like on social media, right? Oh, Nigeria, what Nigeria has happened to you. What does that mean? I know. You understand? And we often forget that we benefited a lot of things from Nigeria. Almost all of us seated here, that we went to public investing, Nigerian government paid our tuition. So Nigeria has happened to us positively. So we should try. Absolutely, absolutely. So, but of course, naturally, anywhere in the world, if you attempt to solve one house, please, anywhere in the world, if you attempt to solve a problem, whether you like it or not, other problems are created. And what is important is to look at other problems and solve them. There are a lot of things that we need to do. We need to expand the pool of funds, to expand access to service. But we have the issue of quality to deal with as well. And part of the quality is the issue of the commodity you are talking about, because part of the commodity supply chain is even the drugs we are talking about. You cannot have a quality care service, you don't have quality commodity. So I think those are other things we have to look at. So the summary is that there's a problem, we made some progress, there are still other problems to solve, but collectively, with the leadership we have demonstrated, we can do a better job. Thank you very much for listening. I forgot to thank our panelists. Thank you very much, distinguished and other panelists, for this wonderful contribution. Let's snap picture. And thanks, Anatu, for putting this together.